Good afternoon, everybody. So we are on to the second session on gastrointestinal symptoms. Mainly, Dr. Sreedevi is going to deal with constipation and intestinal obstruction. So you might be wondering why we should talk about constipation. Uh, so constipation is actually not only patients, all of us might be suffering from constipation, and especially patients who are in palliative care may suffer more because of many factors: reduced mobility, multiple medications, and so on. And decreased food intake, fluid intake. All these are factors contributing to constipation. And constipation actually can cause many uh, complications, including delirium. So that is one of the main topics. And in intestinal obstruction, uh, the usual treatment what we do or what we have practiced is nil per oral, put nasogastric tube, continuous pulse tube aspiration, IV antibiotics, and things like that. So we also need to think about the patients who are near end of life. Do we also need to treat them in the same way, or do we have another way? So Dr. Sreedevi, who is a palliative care physician at Pallium India, will be talking about these two topics. So Sreedevi, the first session was already taken by Dr. Sreedevi. So she has done her MSc in palliative medicine, and she has uh, many years of experience in palliative care. So welcome, Sreedevi, and it's over to you.
Thank you, sir. Thank you, everyone, for one more session on GI symptoms in palliative care. Raju, is my voice enough? Last time it was very less, so I just wanted to check before I start.
It is good now, ma'am.
Okay. Okay. Yeah. So I'll start presenting from my side. As Dr. Sunil was mentioning, many people wonder why do we have a session on constipation per se, but it is one of the most, I must say, very common symptom that we encounter in a palliative care setting, and often an overlooked symptom. Many times we focus more on many other symptoms, and we don't think constipation can bring in a lot of trouble like this. So we keep it aside and start treating other symptoms. It is not very uncommon, especially in a crowded OP where patient comes and talks about the symptoms. We often overlook the symptoms like constipation, because it will be the patient will be slightly embarrassed to talk about the bowel habits, and we won't give much attention to such habits. So today we'll be dealing with what exactly is constipation, why it is important to discuss about constipation, what are the common causes that we see in palliative care setting, the causes of constipation, and how do we assess and manage constipation. So, definition wise, we can say it is uh, passage of small volume of feces infrequently and with difficulty. So, here we need to focus on two things. I must say three things. First is the volume of feces, small volume of feces, and not very frequently as before. Like sometimes the people will have different habits in terms of bowel opening. Some people will have regular daily bowel opening, some people multiple times a day, some people will have once in 2 to 3 days. So the frequency depends on their previous bowel habits, and ask to assess whether they pass it with difficulty or with ease. So to put the words which make sense would be persistent, difficult, infrequent, or seemingly incomplete defecation. Sometimes they have bowel opening every day, but they may feel that the defecation was incomplete. I didn't feel quite satisfied after opening my bowel. So these are the common terms. So we know how the fecal matter is formed. Liquid enters the colon from the small intestine, and then it is moved along the intestine. And as and when it moves, the more and more water is removed, and the fecal matter will become hard. When there is excessive water removal, which will cause really hard stools. So I must say this is a the most mismanaged symptom, because there are a lot of misconceptions around constipation, and I said we usually overlook the side effects. We don't give much attention to the bowel habits generally. Misconceptions would be that patients will relate constipation or bowel opening habits to diet. When it comes to patients who are in palliative care, they may be either in having cancer or might be having in some kind of debilitating illnesses. So they generally eat less, or the diet may not be that good. So people, you might have heard people telling that I am eating less, so bowel opening is also less. So that is a real misconception, not just among patients and families, but among physicians also. Because I have heard myself several times when the patient is having severe constipation and telling the doctor that I have not opened my bowel for 2 to 3 days, then anyway you are not eating much. So that is a very very common misconception. That is one thing that we need to fix in our mind, and we need to tell the patient and the family repeatedly that the quantity of diet doesn't have much effect on the bowel opening. Of course it is not like it is totally unrelated, but we cannot say that I am having not having bowel opening because I'm not eating adequately. um, a lot of other psychological factors that we generally don't discuss. Suppose a patient is admitted in a general ward or in an outpatient, he may have to come every day for radiation. The privacy and the convenience matters. He may not be able to have the bowel opening in the morning before he leaves for hospital. Maybe he leaves very early morning, could not have bowel opening. And of course in hospitals people don't prefer to have a proper bowel opening, right? So there is a matter of privacy, and there is a matter of convenience and comfortable place which we don't actually discuss. Even we ourselves, while we travel or we stay somewhere else, we just don't feel like going to the toilet, right? So that is more profound in patients who might be going through this every day. And there is another factor called loss of control. Many a times people, the patients might be bedridden, or they may have incontinence of bowel. So then there is loss of control on our own body. A small thing like bowel opening becomes a big ritual where you have to call the caregiver to clean it up, and there is a loss of dignity over there. So there is a lot of psychological issues happening. Sometimes they tend not to eat or drink so that there is no bowel opening, or sometimes they, even if they feel like going to the toilet, they try to control it for many reasons like this. And we don't discuss or much go much deeper into these kind of issues. And the side effects of constipation are, after coming to palliative care only I realized that these much events can happen just because of constipation. So it affects a lot of stuff, starting from quality of life, starting from improper symptom control, distress among the family, not knowing that all this is because of constipation, and getting a wrong treatment not knowing that the patient is constipated. So a lot of side effects, just starting from the very cause of constipation. Many a times suboptimal use of laxatives, that happens both from the physician's part as well as from the patient's side. Sometimes we prescribe laxatives, but then the patient feels that it is okay, anyway I'm not eating, so I'll take, instead of one tablet or one 15 ml, I'll take a little bit lesser, maybe 5 ml. So they themselves adjust or reduce the laxatives. One, they think that it is okay not to have a bowel opening. Second, they don't want to or depend on their caregivers to have to help them up to go to the toilet. Those kind of logistic issues. So suboptimal use of laxatives. Sometimes physicians themselves are may not prescribe optimal or the appropriate laxative. That will be another reason. And sometimes the patients present with atypical presentations, like they may say dyspeptic symptoms, or they may come up with urinary retention or urinary tract infection. Sometimes they come up just with delirium, and then we have to track back why this happened. And while doing the correcting the correctable, then we may end up understanding that okay, this constipation might have been the reason. And sometimes they come up with overflow or spurious diarrhea, which is a very very mismanaged symptom. So this is a Rome criteria, which is might be familiar, not used in a routine clinical practice, but for documentation purpose, we can use this Rome criteria. Or if you're confused whether you're actually looking for the real constipation, you can just go through this. Uh, it should satisfy at least two or more of the following. At least straining at least 25% of the defecation, the sensation of anorectal obstruction at least 25% of the time, hard lumpy stools at least 25% of the time, and fewer than 3 bowel movements per week. If you start looking for this, many of the patients that we treat, that we see day to day will have this constipation, especially if you are working in a cancer setting, or you are in a palliative care setting where you see people are more debilitated, and or maybe people may be bedridden. So very often you might be seeing patients satisfying more than two of this criteria. So why should we worry much about constipation? Why should we focus more on treating constipation? Because many of the patients that we see will have advanced illness, and in advanced illness it can increase the colicky pain, or it can itself can cause colicky pain. Anorexia, very often patients tell you that I'm unable to eat, I'm not hungry, or the caregivers will tell you my husband is not eating, not drinking. So anorexia will already be there, and this constipation will aggravate the existing anorexia. Nausea and vomiting, we dealt with this last week, and we know that constipation can be the sole reason for nausea and vomiting. Urinary retention, very commonly patients, very commonly patients come to OP telling that not passed urine. The moment you hear that, ask about the bowel pattern, very commonly they'll be having constipation for more than few days. Anxiety, especially old people, when I have seen that when they don't have their regular old pattern bowel opening, they feel much more anxious that I didn't have this, so I cannot eat much. I should not eat much unless I have a complete evacuation. In elderly patients, very commonly they present just with confusion and delirium. They just come up with delirium and confusion. No one might have noticed that they had a history of constipation, and then when we track back to the to understand what is the cause of the delirium, we may end up understanding that this patient had constipation for maybe days to weeks. No one might have noticed. So what are the causes of constipation? We know that many of the drugs that we use here, I have mentioned the drugs specifically that we use in a palliative care setting, not the other, all the drugs that that cause constipation. These are the drugs that we use very commonly: antacids, anti-epileptics, which we use for neuropathic pain. Many of the antiemetics, for example, ondansetron, the 5-HT3 antagonists, they are known to cause constipation. Many of the anticholinergic drugs that we use for controlling nausea and vomiting can cause constipation. Opioids, very commonly used, antidepressants, many of the antipsychotics, sucralfate syrup or tablet. These are all the drugs that we very commonly use in our setting, which can cause constipation. There are many metabolic reasons for constipation. People don't eat or drink much, so they might be dehydrated. Uh, they may be having hypercalcemia, especially when they have multiple bone metastasis. You must suspect when they come up with severe pain, nausea, vomiting, constipation, and confusion. Then you might consider hypercalcemia. When there is hypokalemia, we know that there is less GI peristalsis, and they may end up in constipation. And uremia. Neurological, sometimes in cancer patients we encounter malignant spinal cord compression, of which one constipation would be one of the very common presenting symptom. And sometimes with huge tumors or any other tumors which infiltrate the sacral nerve can also present as constipation. There can be structural reasons like large pelvic tumors, or sometimes radiation induced fibrosis. Sometimes there is some painful anorectal condition. Sometimes, irrespective of where the cancer is, they might be having a painful hemorrhoid or bleeding hemorrhoids. Then they hold the fecal matter because they are worried about bleeding and pain. So that might be one reason. And sometimes there can be obstruction due to the lesion. Uh, when you start asking questions about depression, as Dr. Sunil mentioned it vaguely last week during our discussion with the patient, sometimes when we ask questions to find out whether the patient is depressed or not, one criteria, a very important criteria, would be that generally they'll be constipated, along with loss of interest, anhedonia, hopelessness, worthlessness. Constipation would be one symptom that you can ask about. Diet, we know that our patients don't eat or drink much, and we can't insist on much of fluid intake or fiber intake because already they'll be having anorexia, nausea, vomiting, lot of treatment going on. So we can't insist much on diet, but this kind of diet can contribute to constipation. Many of them will have comorbidities like diabetes and hypothyroidism, which is already we know that these are all reasons. And many of the patients might not be moving much. They might be either bedridden, or when they are back from the hospital, they sit, or max to max they walk inside the home, not more than that. Very often, majority of the patients. So this immobility and inactivity uh, can be one reason. Advanced age can be another reason. Inability to obey the call is very, very important because many a times, uh, in many home setting, the toilets will be outside the home. They may have to get out of the room and then go to the front door, get out of the house and then go to the toilet. And in many places in rural India, I don't know whether they have the toilet facility or not. And when a patient is really debilitated and needs support to get out of the bed, and suppose the wife is in the kitchen doing something, or the kids are getting ready to school, and you want to have a bowel opening, you just don't feel like calling someone, right? You feel, okay, it's okay, I'll hold on, I don't want to bother them. So they may hold on for some more time, and it may end up in constipation. So inability to obey the call might be due to the physical distance between the toilet, or might be due to the family issues, many reasons. So inability to obey the call is one reason people very often end up in constipation. So, what are the common causes again in palliative care patients? Very specifically, opioids. We have heard, you might have heard in the opioid session that how about 97% of patients on opioids will have constipation. So, has a very, very strong association with constipation. Very less, very, very less, you will see patients having not dependent on laxatives, having good bowel opening with opioids. So opioids is one important reason. Dehydration, as we mentioned before, reduced mobility, hypercalcemia. So these are the same reasons that we see in general population, but more specifically, we see all these reasons very, very commonly in a palliative care setting. And the drugs that we mentioned, anticholinergics, antacids, especially the antacids with aluminum salts. How morphine causes constipation? You might have heard this, but just to brush up your memory, it decreases the propulsive intestinal activity. It increases the non-propulsive activity. So it tells the intestine not to move generally. It will do everything so that the intestine is not moving at all. And so what happens then? There is additional time available for water reabsorption. So we saw the picture in the beginning where the more the transit time, the more water reabsorption happens, and the fecal matter becomes generally very, very hard. And there is inhibition of secretomotor neurons, so very less fluid enters the gut. So you are taking out whatever water it had. You are the morphine is reducing the bowel movement, and along with that less fluid is entering the gut. So and reduces the sensation of rectal distension. So there will be fecal impaction, there will be hard stools. The stools become hard because of water reabsorption. The stools are not moving because of the interaction with the propulsive activity, and there is less. So hard stools not moving, along with that there is fecal impaction. So these are the picture that we get in morphine induced constipation. So, how do we assess constipation? Daily assessment. Every single day when you go for rounds, or in our setting, when the doctor is going for rounds, every single day, the patients, along with any other symptom, the pain, nausea, vomiting, whatever symptoms, we ask about bowel opening. Make sure that we ask about bowel opening. Every OP visit, we ask and we record whether the bowel habits are normal or not. And not just asking whether you had bowel opening. When we learned pain, the one thing, very important thing that we learned is that to trust the patient, right? To trust the patient, believe the patient when they say they have pain. Don't be judgmental. But I think when it comes to constipation, Never trust the patient and the family. Keep asking questions, and finally, you may find that the patients might be having weeks of constipation because they either they overlook the symptom, or they'll be embarrassed to talk about it, or they say it's okay, it's after all it is just about bowel opening, nothing big. So ask all these questions every single time you ask about the bowel opening. When was the last bowel opening? So the first question would be, how about your bowels? Are you having proper bowel opening? Then usually the answer will be, yeah, yeah, it's okay, I don't have any problem with the bowel. Then ask, when did you have the last bowel opening? Very often it will be 2 to 3 days back. And then you ask about the stool consistency, size and volume. Was it hard? Was it enough? Was it small quantity? Then the story becomes bigger. Then it unwinds. A lot of mysteries get evolved there. Oh yeah, I have very hard, lumpy, small stools, but it is okay. I'm open. I go to the toilet every day. Okay, is it a satisfactory? It is a complete emptying. Do you feel satisfied? Okay, my tummy is clean after bowel opening. No, I don't feel that. Anyway, I'm not eating and drinking. So you will hear 10 times during your conversation that I'm not eating and drinking. At least the family member will interrupt and tell you, no, no, he's not eating and drinking. Then how can he have a proper stool? Where it is coming from? So you have to ask all these questions. What was the consistency? What was the volume? Was it hard? Was there any blood? Was there any black colored stools? Whether you were able to pass it freely, or did you have to struggle a lot? Is there any incontinence? Do you feel like you just don't have control over your fecal matter? Do you feel that it is kind of leaking? So these are all really, really important questions. You just start asking these questions, and then you'll be really surprised to hear the answers, because we generally don't ask this much about constipation. So this is a very commonly used chart, which is Bristol's stool chart. If you are unable to ask or put it in words, how to ask these fecal matter consistency and stuff, you can use this picture and ask them how well you can relate this with your daily bowel opening. Very, very commonly they say type 1 or type 2. And they pass it with difficulty. They don't want to tell the caregiver because they are undergoing major treatment, major symptoms. How can I just crib about not having proper bowel opening? So they just don't discuss that. So this is a very effective one. You can keep it in your mobile phone. You can show it to the patient and ask. Very, very, very simple one. If any suspicion, ask more questions, do examination. Examination, as I mentioned last week, should start from the oral cavity. Check for dehydration, check for oral thrush, check the abdomen, listen for bowel sounds. And uh, as I said earlier, don't trust the patient when it comes to constipation. You have to ask many questions, and if you are still suspicious, ask permission to do a gentle rectal examination. Ask permission, explain the procedure, do it really gently, but yeah, don't leave your suspicion behind. And if needed, you can always ask for an abdominal X-ray, but very rarely we need an X-ray. Rectal examination, make sure that you explain the procedure to the patient, because it is not a pleasant thing to go undergo. Even whatever the situation may be, I may not want a rectal examination for me. So it's not really pleasant for anyone. So explain the procedure to the patient. Explain why you are doing this. What are you trying to do there? What are you trying to help him with? And use a lot of lubricant. Tell them to relax. Keep talking to them when you do. So then make the procedure easier for them. While doing rectal examination, I know that I don't need to teach you all this, but just kind of revision. If the rectum is empty and collapses, we know that it is a very good functioning bowel. Just if you feel the rectum just gently hugging around your finger, you know that the rectum is okay. If there is rectum is empty and dilated or balloony, you feel a lot of space around your finger, that means the feces is somewhere high up in the bowel. uh, that is indicative of gross constipation. So the patients may not actually tell you. So what the relatives feel that every day the patient might be going to the toilet at least 4 to 5 times a day, because the patient is not having a complete evacuation. So he keeps going. It is not complete. He goes again and comes back. The relatives will be thinking that anyway he's going 4 to 5 times a day, so how can he have a constipation? So that is one thing that you need to figure out between talking with the caregiver and the patient. And if there is fecal matter in the rectum, always examine your finger when you take it out, whether there is any blood, which is a fecal matter, whether it is hard or soft. And if possible, do a rectal evacuation, digital rectal evacuation. And if make sure that you are not touching a tumor mass. If the surface is irregular, hard, and immobile, probably you might be touching a tumor mass. Then you may not need to proceed and refer for further evaluation. So this is the first picture shows a normal rectum where the fecal matter is there, and the sphincter muscle get the signs, so you can have a normal bowel opening. The normal reflex will be there. But when there is more stool, you can see the rectum is completely enlarged and dilated. Only the hard part of the stools will come up to the rectum. And what happens to the rest of the stool? The softer ones go back to the colon. So it gets lodged there. Only the liquid content or the fluid content oozes out of the in and around the fecal matter, comes out through the anus. So the patients will come up with diarrhea. I am having loose stools. So make it a practice when you are in palliative care. The moment you hear diarrhea, ask when did they have the last bowel opening. Very commonly it would be weeks back or days back. So prolonged constipation, the liquid, the fluid around the fecal matter oozes out, and then they come up with this complaints of diarrhea. Then you go back and ask about constipation. With good bowel regime, you can treat this so-called spurious diarrhea. So don't get confused, don't trust, ask whether, make sure that it is actual diarrhea, not spurious diarrhea. So prevention is the key for managing constipation. The hand that charts morphine should chart the laxative. When you write the prescription, make it a habit. The moment you write morphine, without jumping into any other medication, start writing a laxative, the appropriate laxative. Non-pharmacological measures you have to assess daily. If at all possible, improve the mobility. If possible, access to toilet facility. You can just give a commode chair. A plastic commode chair won't cost too much. That will solve many problems in many households. And if possible, prompt response to patient's call. Privacy in a ward setting, ensure that the patient is given a screen or some kind of privacy so that they can have a good bowel opening. If possible, we can always advise about diet and fluid intake, if possible, not in a bedridden patients who can't have anything at all. You can't talk about the fiber rich diet. And ask about any other associated symptoms like urinary tract infection, the delirium, confusion, any other symptom, pain, anything. So this is a basic classification of laxatives. We have a lot of laxatives available in the market, and you can put them under these headings. The first one would be bulk forming laxative, fecal softeners, which will soften the fecal matter, osmotic laxative, stimulant, which will stimulate the gut so that the fecal matter pushes out, and others like prokinetics, which is not primarily used for managing constipation, but it will help in managing constipation. So I'll go through this quickly. Bulk forming, we generally don't use it much in palliative care because it makes the stool bulkier, and the patients don't have much of gut motility, and they'll already be debilitated, and it will absorb extra water, and they might be already dehydrated. So we don't use it regularly. Osmotic laxatives, very commonly used, pretty expensive actually. To be taken in the adequate dose, this costs a lot. Many patients tells us that we cannot afford to buy this lactulose. It is a non-absorbable sugar. It has an osmotic influence, causing retention in the lumen. It can cause dehydration and cramping and nausea. Again, we do use it in some situations, but not generally in the first line of laxative. Fecal softeners, which will soften the hard fecal matter, it is not used alone. If you just give a softener, only the some part will soften and it will come out, so you are actually aggravating it, and the patient will keep having leaking. So we cannot use it alone, but it is good to combine with a stimulant laxative. What does a stimulant do? Stimulant will stimulate the bowel movement. So we know that the morphine will decrease the propulsion, so we need something to push the fecal matter out. So bisacodyl is one of the very commonly used stimulant laxative in our country. There are many other, but this is the available one and the very commonly used one. We cannot give it in complete bowel obstruction. And this can be a model prescription. You can start with bisacodyl 10 milligram night dose. We give night dose so that the patient, it will take time, almost 12 to 8 to 12 hours. So in the morning, they will have adequate bowel opening. So you can start with 10 milligram HS with or without softener. Depending on, so that it depends upon your assessment. Ask whether the problem is hard lumpy stools. Ask whether it is the difficulty in more of straining associated. So depending on that, you can combine with or without softener, and then you can go up to 30 milligram a day of bisacodine. Um, the softener can go up to 60 ml when it is liquid paraffin. It comes with so many preparations with cremafin, with stimulant, without stimulant, etc. And rectal measures, when you do a rectal examination, if possible, do manual removal. And if you feel that the rectum is loaded and it doesn't and it is okay to give suppositories, but if you feel it is a balloony rectum, give low or high enema. So just listen to me carefully. High enema is a procedure that we do very commonly in palliative care. So we have seen how high the fecal matter is impacted when it is a long standing constipation. The low enema tip will not reach there. You are just giving somewhere near the anus and it is not going to go anywhere. It just comes out as the liquid itself. So in that case, you can either use a long a red rubber catheter or a suction catheter or an LCath, any tube which is long, attach it to the tip of the enema sachet. Insert the tube as much as possible gently. Use lot of lubricant. Insert the suction catheter as much as possible without any obstruction. The moment you feel obstruction, stop there, administer enema. So you are actually trying to bypass the obstructed fecal mass and giving enema. So when you do a rectal examination, if you feel the rectum is balloony, dilated, no point in giving a suppository or low enema, then you have to administer high enema. So this is one thing that you might have to start practicing. Make sure that you are not treating diarrhea per se. Assess whether it is spurious or overflow diarrhea. Ask, it will be usually sudden onset of diarrhea after a period of constipation, and this shows that there was a chronic constipation and fecal impaction. Do a rectal examination or digital evacuation if you feel any suspicion. Make sure that and when there is a spurious diarrhea, there is no point in just giving laxative and sending the patient back, because it will be really difficult. So then you have to do a proper rectal examination, give a high up enema, along with that regularize the laxative, step up or add the softener or however it was, and make it regularize. So this is how we have to look constipation. It is a symptom, not a disease, but it is a very mismanaged symptom and very overlooked symptom. Laxatives will not work if you don't give it at all, or if you don't ask or talk about constipation. All the laxatives work, but adverse effects and palatability. Sometimes people feel like vomiting when they take the liquid paraffin or something. So you have to ask them which works for them best. Generally, in palliative care, we may need a combination of a softener and stimulant. So this is quickly about constipation, because we have one more topic to deal with, and we'll take the questions together after the bowel obstruction. Uh, sorry. Yeah. So bowel obstruction, again, we discussed a little bit during the last session, because the presentation was mostly about malignant bowel obstruction. Today we will be dealing with signs and symptoms with radiographic evidence obstructing the transit of GI contents. Today we'll limit our presentation to cancer and anti-cancer related bowel obstruction, because it's a very wide topic. It is a very difficult area with considerable variation in signs and symptoms and approach to management. So you really have to understand what are the symptoms. Like we said in nausea and vomiting, we need to understand why the patient is vomiting. Same way, why this obstruction, where can be the obstruction, what are the symptoms. According to the symptoms, we have to take approach to the management. It is not a single way to tackle the situation. So how common it is? It is very commonly seen in advanced stages of cancer. So today we'll be discussing mostly about cancer and anti-cancer related bowel obstruction. It is very commonly seen in advanced cancer. And when there is a bowel obstruction, generally the expected survival is about 1 to 3 months. So it is seen during the last or advanced stages of illness. It can occur anywhere in the GIT, starting from esophagus to rectum, anywhere. Very commonly, the most common site is small bowel, and it is very commonly seen and associated with gynecological cancers, followed by colon cancer. And we may see obstruction in other cancers also, totally unrelated to the GIT, might be breast, gastric, lung, or pancreatic cancers, but very commonly seen with gynecological cancers. So, what are the different types of obstruction? It is self-explanatory, partial or complete. When you have some space in the intestine, or complete when the obstruction is completely, the GIT is completely obstructed. Mechanical or functional obstruction, it can be at single site or multiple sites. It can be intraluminal or it can be intramural, where there is infiltration in the intestinal muscles itself. It can be obstruction from outside, where we call it extrinsic obstruction. So these are the various types. It is, I'm not going explaining word by word because it's kind of self-explanatory. And we are bothered more about the partial or complete, or exactly where the site is when it comes to management. uh, uh, Many times during the treatment itself, patients will end up in obstructions. For example, after surgery, there can be adhesions, or following a chemotherapy, there can be reactions which will end up in bowel obstruction. Sometimes there can be torsions or internal hernia. So the treatment itself can cause a lot of uh, can cause a bowel obstruction, not just the tumor mass. Very rarely we see pseudo obstruction, where actually the nerve is destructed, the enteric neurons destruction is there. So it will end up in having obstruction, so not because of a tumor per se, but the tumor has invaded the nerve, and the nerve is causing all the signs and symptoms of bowel obstruction. Sometimes the drugs can cause ileus. Morphine itself can mimic the signs and symptoms of bowel obstruction. Nerve related, like diabetic neuropathy, patients will come up with all the signs and symptoms of complete bowel obstruction or partial bowel obstruction. So we'll come to the sorry. How can we? Sorry, I'll just. How will we understand what is happening, what is the pathophysiology? So it's like a cycle, one thing lead to next, the next thing lead to next, so it's like exactly like a cycle. So imagine there is a block in the lumen. Okay, the GI tract is like literally like a pipe or a tube. There is an occlusion in the tube which will prevent further propulsion of contents, right? So there is a block, so it will not let the intestinal contents to pass distally. So that is the initial stage. At this stage, what happens? The bowel will try its best so that all these contents should pass distally. It will keep moving so that the contents should bypass the obstruction. At this stage, it's the initial stage and it may be reversible. But what happens if it is not reversible? The bowel will keep trying bypassing the obstruction, keep moving, more and more contractions. And what happens? It becomes it turns into an uncoordinated way. Sometimes the bowel will succeed in overcoming the obstruction, but many a times it may not, and all the contractions will uh, become haphazard. It becomes in an uncoordinated way. And when the bowel is trying really hard to push the contents, what happens? There will be more distension. Whenever there is more distension, there will be more and more secretions, and this will become a vicious cycle. So it is written in this figure. Whenever there is more distension, more and more secretion will happen, more and more water reabsorption will also happen. So this will cause more distension. Again, this will cause more and more secretion. This becomes a vicious cycle. So what happens? There is a tube block in the tube, and there is lot of contents being blocked above it. So it's like a blocked sewage. When there is more and more block, everything becomes stagnant, and what happens? The bacteria will come into action. So there is increase in bacterial flora, and whenever there is bacteria, there will be gas which will cause more and more distension and pain. So it's exactly like a blocked canal or a sewage, where if the waste water is not moving at all, there will be more and more bacteria. And we know that while walking near it, we feel foul smelling atmosphere. Exactly that's what happens in the bowel also. So when the bacteria is there, there will be more inflammatory response, causing release of all the inflammatory mediators. So whenever there are inflammatory mediators, what happens? There will be bowel wall edema. So already you have a blocked lumen. Along with that, the wall itself will have edema. So the wall is getting engorged because of inflammation, which will give more and more uh, 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 features of obstruction. So because your lumen has become really small because of the edema. So again, I'll just repeat, there is a small obstruction. The bowel will try to bypass the obstruction by moving again and again, failed. So the contractions become so severe. Again, this thing is not moving. It's everywhere. The content is completely obstructed, which will cause distension of the bowel. Whenever there is more distension, there will be more secretion. More secretion means more distension. So it becomes a cycle. So the things are not moving. There is more bacteria coming into play, which will release gas and inflammatory mediators. So whenever there is inflammation, there will be hyperemia and edema of the bowel wall. So everything becomes a mess now. So whenever there is no venous drainage from the obstructed part, there will be hypoxia. So there will be redistribution of blood flow from the obstructed segment and distal side. So there is a complete redistribution of blood flow because the venous drainage is impaired from the obstructed sites. And there is alterations in the splanchnic blood flow, which can lead to multi-organ failure, which we'll see in a very late stage of obstruction. These are the metabolic and septic consequences. Whenever there is a hypovolemic state, it can cause functional renal failure because there is decrease in renal blood flow. Because there is total hypovolemia, there is decrease in renal blood flow, which will cause functional renal failure. And we know that there will be dehydration, which will cause oliguria and hemoconcentration. When the obstruction is at high level, there will be stasis of biliary, pancreatic, and intestinal secretions. So what happens then? There will be metabolic alkalosis, hypokalemia, hyponatremia, everything happens. And there can be sepsis. I'm not complicating this. We just heard that how bacteria can affect all this. There will be passage of toxins and intestinal contents to the circulation. This will lead to sepsis at later stages. So, what is the rule of thumb? This we can remember so that it becomes easier. Higher the obstruction, more symptoms and less signs. Lower the obstruction, less symptoms and more signs. This is how we can assess whether the obstruction is complete or obstruction is proximal or distal. So signs and symptoms, we this depends on the site of obstruction. So again, imagine a drain tube from the wash basin in your home. Okay, you have a block in the draining tube in the wash basin in your home. Suppose the block is right at the outlet, right where you wash the hands, right at the outlet. What happens the moment we wash the hands, the moment we use the wash basin, you can see the water is not going down, everything is coming up very early. The volume is large. It is not foul smelling water which is coming up because you just washed your hands. Same thing with gastric outlet obstruction. Early symptoms: severe nausea and vomiting, high volume vomitus. Easy to remember. What happens if the obstruction is way down in the wash basin drainage tube? You can keep washing your hands, you can keep using the wash basin maybe till night. You feel it is okay, there is no block, water is going down, but you can hear some noise because some obstruction is there somewhere. We can hear some noise, and by around night, when you're done with all your work in the kitchen, then comes slowly oozing up of water. Then you realize that the wash basin has been blocked somewhere near the out, very far from the outlet. Same thing with the small bowel obstruction. When the obstruction is distally, initially you won't feel much of the symptom, late onset of symptoms, but more cramping. Later, come up with nausea and vomiting. So everything, the nature of nausea, nature of vomiting, the nature of vomiters, everything depends on the site of obstruction. So when you relate that to your wash basin, it is easier to remember. Very silly way of remembering things, but yeah, it helps me a lot to remember that way. In large bowel obstruction, symptoms appear later. The patient might keep taking sips of fluid till evening, till night, but he may have lot of distension because he is eating and drinking. Somewhere out there, there is obstruction, lot of bacterial overgrowth because everything is accumulating for a longer period of time. Pain, so we move on to the symptoms. So symptoms also depends on where the obstruction is. There can be two types of pain. One, there is a continuous background pain along with the crampiform pain, especially when they take meals. So two kinds of pain they usually tell you: nausea and vomiting. So what happens when the wash basin is blocked right at the outlet? We know that the vomitus is generally fresh. Biliary in small bowel and gastric outlet obstruction, the patient will tell you immediately after any intake, I vomit. I had a black tea, it came out exactly like the black tea. I had kanni and it came out exactly like kanni. The same thing without any delay. So that means the obstruction is somewhere right at the outlet. So, and if the patient is telling very foul smelling vomiting, I can eat or drink till night and then I vomit everything together, foul smelling, sometimes feculent in large bowel obstruction. Constipation, flatus and stools are absent in complete obstruction. Very important question to ask the patient: are you passing gas? There will be constipation in whatever obstruction. Very commonly we encounter with constipation, but ask the important question to rule out whether it is partial or complete, whether you can pass gas. If the patient is telling no, I feel like passing gas, but the gas is not going out, means you have to suspect complete obstruction. Listen to bowel sounds. So this is summarized in a table where you can differentiate when it is proximal obstruction and distal obstruction. What happens in proximal obstruction? The pain will be generally around the umbilicus because we know that the obstruction is somewhere near the outlet or very, very proximal. So the early symptom, the wash basin will get blocked the moment you wash hands. The moment you eat something, vomiting will happen and there will be short intermittent cramps. It will be generally around the umbilicus. The patient can literally point it, point exactly where it is happening. Here it is, I feel pain when I eat something. But in distal obstruction, the pain and nausea and vomiting comes really late. They generally can't point it. They say deep, it's kind of stomach pain. And there will be long intervals between the cramps because it is in a distal site. What is the difference in vomiting? When they vomit, large amount, watery or bilious, no foul odor in proximal obstruction because it is right at the outlet. The moment you eat something, it will come out. In distal obstruction, they can eat sips of fluids. As I said earlier, small amount of vomitus will come out, very foul smell, and generally volume might be really less, very less amount. Distension is usually absent in proximal obstruction because it's not anywhere far. But when there is a distal obstruction, we know that everything is obstructed. As you hear noise in the wash basin, you keep washing in the morning time, you can hear noisy passing of gas through the outlet tube. The same way in a distal obstruction. Constipation may be present in proximal, but in distal obstruction, there will be definitely 2 weeks of constipation. So this is a table which you can differentiate whether it is a proximal or a distal obstruction. Continuous and partial, you have to ask whether the patient is able to pass gas. That's one simple thing that you can do. It comes rarely as an emergency. This is kind of expected when you are encountering with some of the gynecological tumors. The mass from outside is causing obstruction. We know that there's a colon cancer. It rarely comes as an emergency. You get to plan and communicate with the patient that this is a possibility. And any management in bowel obstruction depends on the disease stage of disease trajectory. We need to understand where exactly in the disease trajectory the patient is in. What is the goal of care? Very commonly, as I said, bowel obstruction comes in an advanced stage of illness. Very commonly, the goals of care would be palliative and supportive, not curative. Very rarely it comes to the under the curative thing. Only if the patient is coming first time coming presenting to a gastrosurgeon with obstruction. Unless in that situation, it might be curative, but otherwise it all comes under palliative or supportive care. So to decide How should we manage this? We need to understand where exactly in the disease trajectory the patient is in. We need to communicate with the family regarding the goals of care. And very importantly, we need to control the symptoms like pain, nausea, vomiting, constipation. And very rarely we need investigations, which will be minimal also. We may need to check the electrolytes and check hydration. Abdominal radiograph would be the maximum extent of investigation that you may need in a palliative care setting, and we need X-ray erect, abdomen erect. We can see multiple air fluid levels. Plain X-ray abdomen. Uh, it's not the investigation of choice, but in a palliative care setting, we generally rely on that. When there is a distal obstruction, we can see dilated bowel loops or air fluid levels. It is also help. It also helps in ruling out constipation or pseudo obstruction. The investigation of choice would be CT scan because it is 100% uh, sensitive and specific. It can locate where exactly the obstruction is, whether it is single site, multiple site, partial, complete. What is the situation of the bowel wall around the tumor? Whether there is any obstruction in the lymph around there. So everything can be understood from a CT scan, but very rarely needed in a palliative care setting, unless you are actually seeing the patient for the first time and you are going to be in the diagnostic phase. CT scan might help, but otherwise, because the treatment would not depend on many of this in a palliative care setting. So coming to management, again emphasize on frequent mouth care. There is a tendency that when a patient is sick and admitted in a hospital, especially with a GI symptom, stop taking care of the oral cavity. They just stop brushing. I don't know why, and why do they think like that. It just comes out of picture about the oral care. But ensure frequent oral care. Check for dehydration, check for oral flush, or any other issues in the oral cavity. Offer ice to suck. We know that the patient may not be eat or drink properly in case of bowel obstruction. You can tell them to suck some ice, having sips of fluid so that the mouth will keep hydrated. And if the patient is not really dying and you want to maintain hydration, you can give subcutaneous fluids for long term. But if the patient is severely dehydrated and patient is not that bad, not literally dying, you can always correct by IV hydration. Very importantly, we have to choose the route of administration, as in nausea and vomiting. So, how to control pain in bowel obstruction? So, we saw three main symptoms: pain, nausea, vomiting, constipation. So, we start with reducing pain. Pain, definitely, we start with opioids. Depending, you need to do the pain assessment out of 0 to 10. What kind of pain, quality, provoking or palliating factors, everything you have to assess. And if it is severe pain, we can start with opioids. Generally, they need opioids, and you have to choose which route of administration because they'll be having vomiting, and depending on the where the tumor exactly is, the absorption might be a problem. So we have to choose route, either subcutaneous, sometimes rectal, sometimes transdermal. So depending on the symptom, we can choose the route of opioids. And the second line of treatment would be steroids, and the third would be antispasmodics. Steroids, how does it act? We very briefly mentioned it during last session. Dexamethasone is the most commonly used steroid. I think in palliative care setting, we generally use only dexamethasone because of less mineralocorticoid action, plus longer duration of action of dexamethasone. The dose ranges from 8 to 16 milligram. Uh, do a 3-day trial and make sure that you don't give high doses late in the evening because the patient will have altered sleep phase cycle. They may not sleep when you give a high dose of dexamethasone at night. So try to give it either morning and afternoon dose if you want to split, or once daily dose. Anyway, the duration of action is around 24 to 36 hours anywhere. And for dexamethasone, you may not need to give it 8 hourly. So either to give a single dose in the morning, or if you want to split, you can give morning and in the afternoon, anywhere from 8 to 16 milligram. Do a 3-day trial. Check whether the patient is getting symptomatic relief. If not, just stop it. If you think that it is working, you may continue and then taper it down. The main action is to reduce the bowel wall edema. So whenever there is, we heard that in bowel obstruction there can be bowel wall edema and peritumor edema. So this dexamethasone will help to reduce the bowel wall and the peritumor edema. And so now we have a tumor mass in the lumen. We gave steroid which had reduced a little bit of peritumor edema and bowel wall edema. Imagine there is some space so that we can give a prokinetic. Now we need to push the contents to the available space. To push the contents through the available space, we need a prokinetic like metoclopramide. We can start with a small dose of 30 milligram, or you can hike up depending on the response. Either you can give subcutaneous, intravenous, or continuous infusion. Whenever you give a prokinetic, when you are suspecting and you are not sure whether it is partial or complete obstruction, observe the patient. After giving the prokinetic, ask whether there is increase in gut colic. If there is severe colic immediately after you give metoclopramide, that means the patient might be having a complete obstruction. And if you continue to give, what happens? You may end up in a bowel perforation. So be careful when you give prokinetic. Call and ask the patient if the patient is at home, or tell them to call back after taking the medication. Or if in the inpatient unit, you can just monitor whether they have increase in gut colic. The moment they say increase in pain, stop, because you may end up in a bowel perforation. Sometimes you may need to give it 24 hours infusion. Intermittent doses may not work. Very often we may need to switch to a continuous infusion for complete obstruction. So what we did, we thought, okay, this is a partial obstruction. We gave dexamethasone, we gave opioid. So when you gave opioid, the pain reduced. When you gave dexamethasone, there is a small space we got. Through that small space, we tried to push the contents by giving metoclopramide. Did not work. Okay, imagine it was a complete obstruction. What to do now? Now our focus should shift to treating symptoms rather than trying to bypass the obstruction. Stop trying bypassing the obstruction, focus on relieving the symptoms. Then we start thinking about anticholinergic or antispasmodic drugs, which can be given as continuous infusion. So your aim is to reduce the symptoms so that the vomiting is reduced, the volume is reduced, the gut motility is reduced, kind of gut paralysis we are doing. So hyacinth butyl bromide, the commonly used drug would be the Buscopan. We can start with 40 milligram. We can go up to 240 milligram. We know that at higher doses for a long period of time, it has central nervous system actions, but not really very common. We may not usually need that higher doses. Ranitidine infusions, the histaminic blockers are known to reduce the gastric secretion, so you can also try ranitidine infusions. And another commonly used drug in a hospital setting, not commonly used in a palliative care setting, would be octreotide, which is a somatostatin analog. It has multiple actions. It decreases the secretion, so it is generally indicated in a high volume vomiters. So that is simply putting it in words. It is generally indicated in high volume vomiters. Better to give it as continuous subcutaneous infusion, anywhere from 100 to 600 microgram, or some textbooks say 800 to 1000 microgram per day. Intermittent doses usually don't work for octreotide. Very expensive drug, so we need to think before starting. Usually we manage, I think in 9 or 10 years with pallium, we have used only once or twice of this octreotide because of intolerable issues with the Buscopan, but otherwise we manage very well with the Buscopan and the other regime that we set. Very rarely I have used octreotide, unless it is really because it's a expensive drug when you use higher doses as continuous infusion for a longer period of time. And there are strong evidence that it is not superior to the dexamethasone prokinetic, the steroid opioid prokinetic regime. So it's really something that we need to think before starting. And how to control the nausea and vomiting? Sometimes it may get controlled with when you give prokinetic in partial obstruction, but if the obstruction is complete, then you may need to give something You can't give metoclopramide, right, in complete obstruction. Then you may need to switch to haloperidol or promethazine. For constipation, sometimes we may, because you are paralyzing the gut is more not moving, not obeying the usual contractions, then you may not expect a normal bowel opening, but you can try gentle rectal measures. Sometimes very small dose of softener, but generally we rely on gentle rectal measures. So moving on to surgical options. I am mentioning the surgical options. One thing we need to keep in mind, that I put it in the end, in the red. The primary intention of most of the palliative surgeries in bowel obstruction is just to improve the quality of life and symptoms. So when you refer a patient for surgical option, ultimately the patient is going to get a palliative surgery, not generally not a corrective surgery. And these are the surgical options that they usually give. Sometimes they create a stoma so that the obstruction is relieved and there is some bypass, but again the lesion is progressing. Sometimes they debulk the huge tumor. Generally surgeons don't take up if it is it is a multiple site obstruction. If it is a single site obstruction, you can think about surgical option. Again, it is usually a palliative surgery. Interventional or invasive treatment. So I have put NG tube insertion in an interventional or invasive treatment. It is not a casual thing to offer. It is an intervention. It is an invasive intervention. NG tube insertion, very commonly we see people getting NG tube when they have bowel obstruction. So think what is your goal of care here, whether it is helping the patient. If you want to take up all the gastric secretions, like if the outlet obstruction is there and pooling of secretion is there, if you want to vent the gastrointestinal secretions, yes, I may put an NG tube and drain all the secretions as a temporary measure. I will not put it there and just leave so that the caregivers will start feeding through that tube. If the obstruction is really distal, there is no point in giving an NG tube. So it's a temporary measure given in proximal obstruction, and the goal is to vent the GI secretions. Venting gastrostomy, when the patient is unresponsive to medical treatment and you are unable to achieve any improvement in symptom control, and the life expectancy is really low, then you can ask your, if you it is really accessible, you can think about a venting gastrostomy so that the symptoms are temporarily relieved. But again, patients will have massive ascites and lot of adhesions in the stomach, then that may not be an option. Stenting is another option, but stenting is, the failure rates are really high. So you can't just send the patient thinking that it will improve the symptom for a long period of time. Again, it is indicated only for single site obstruction. So again, a very debated topic, TPN, because in a hospital setting, when there is a bowel obstruction, patient is kept NPO and patient will be getting TPN. Very common scenario. So is it actually helping the patient? It is indicated in patients only in patients with minimal tumor burden and candidates waiting for a definitive surgery with a good performance status, not for advanced. There are a lot of evidence, when you just look up for the evidence, strongly against TPN in advanced cancer and advanced stage of illness. It is used in patients with good life expectancy, and especially when they are awaiting a definitive surgery in a few days and you would really want to maintain their good performance status. Otherwise, TPN is not indicated. So to summarize, patients with bowel obstruction, the single important thing to remember, that the moment you start planning, understand where exactly in the disease trajectory the patient is in, and then set the goals of care. My goal is to relieve the pain, relieve the vomiting, relieve the constipation, give a good quality of life. Yes, set the goals prior to management and discuss it with the family and the patient. Pain, nausea, vomiting, and constipation, it should be addressed, and choose the route of administration, whether it should be given parenterally, sublingually, or transdermally, or rectally. And with just these medications, we can make the patient and families really comfortable without any high tech interventions. And a very important thing is communicating with the patient and the family that what exactly is happening, what you are trying to achieve here, what is your goal of care, whether you both are on the same page. Give the wash basin example. Every patient understands that. I love that explanation a lot, because any common man, when you explain that, they will understand exactly what is happening inside their body. They know what exactly you are trying to overcome. They know why this is happening and what you are doing. So it's really easy to communicate with the patient with such simple examples. Yeah, I think I have exceeded time. I'll stop here and I'll take up some questions.
Thank you, Sreedevi. So we can take a few questions. I saw one question in the chat, but I didn't quite understood what it is. Uh, Regarding the tolerance to use of laxatives. Dr. Indu, can you unmute and ask?
Ma'am, whether the patients they develop tolerance to the use of laxatives, ma'am.
You mean that you may need to increase the dose later because patient is not respond? I don't think it's tolerance. Usually, what happens is that many of the patients may not respond with the, some of them, at least some of them may not respond with the 10 milligram HS dose of laxative, or the usual 15 ml of softener. You may need to increase the laxative. I would not say it as tolerance. Actually, I don't
Okay,
tell it
ma'am.
as tolerance. It is generally that some people need higher doses, some people need lesser dose. Yeah, that's it.
Okay,
There
ma'am.
will be
Thank you.
individual variation. Some, even with full dose of laxative, people will come and tell that they don't have proper bowel opening. Very often they may have to depend on rectal measures. One thing I forgot to mention is that in our place we make it any setting, home care, IP, OP, any setting, every single patient has to have a bowel opening every third day. So we keep asking, keep asking. Third day is kind of alarm for every one of us. Third day means you have to intervene.
Is constipation associated with all opioid?
It is more profound with morphine. Uh, Opioids, all the opioids are constipating because the mechanism is like that. But morphine is more notorious in that category than fentanyl and methadone. But yes, you have to give laxatives, even with tramadol, tapentadol, whatever opioids that you are using. Tramadol, I have not seen any single prescription with laxative coming from physicians. It's just tramadol and Emiset. Probably they know that the patient may vomit, but not constipating. Tramadol, tapentadol, morphine, but morphine is the notorious one. Very, very commonly with tramadol.
Madam, Madam, what about phosphate enema?
So,
Phosphate.
yeah, what do you want to know more about it? Like,
Yeah, is it advisable?
yes, that is the it's a osmotic laxative. That is one laxative that is very commonly used in a palliative care setting. Because see, glycerin enema, what happens? It is a very commonly used thing is glycerin enema. So what happens with glycerin enema? It just coats the fecal matter to come out. But the phosphate enema has a stimulant action also, because the reason for constipation here is different. It is not that just hard stools. It is lack of peristalsis and fecal matter stuck somewhere. So we need something to stimulate that. So we know that the bisacodyl suppositories are kind of irritant. It just make the distal bowel move. It's kind of irritant laxative. So we need something to stimulate the movement and soften the fecal matter. So phosphate enema is the recommended one. And if at all possible, teach the caregiver how to keep a suppository, how to give enema. It's not rocket science. Anyone can do all these things. Many of the caregivers might have given suppositories at least to children when they had fever in their childhood time. So it's very easy to teach them how to keep it, not to place it right in the middle of the fecal matter, how to keep it near the bowel wall, how to lubricate themselves and then keep it every third day. Check whether there is no whether there is bowel opening. If no, a third day they can keep suppository. So teach them how to keep a suppository, how to give enema at home. High up enema, generally they may not be that confident, but normal enema they all will be willing to try at home. Many of them we just demonstrate once. So whenever do the procedure, make the caregiver stand near you and observe, so that next time they may, sometimes patients will have to travel a long distance, come to us just for an enema. That's not needed. We can always teach them to do it at home.
Madam, sometimes enema is not working, so we have to do digital removal of the feces.
So, sir, it depends on many factors. If enema is not working, we need to think why it is not working. You have given an enema. Suppose the rectum is ballooning, and you have given an enema. As I said, the fecal matter is somewhere high up there. There is no point in giving up enema in the periphery. It will just go up there and come out, because fecal matter is really hard. Then if you, as you said, if you can feel the fecal matter loaded in the rectum, you can evacuate whatever you can with the fingers, and then maybe you can, depending on the consistency, you can either choose an enema or a suppository, depending on the how long standing the constipation was. So it depends on altogether assessment, including the history and your rectal examination.
Okay, thank you.
Sreedevi, there is a question, what is low enema?
The low enema is the one that is very commonly and the used enema. I think only in palliative care setting we use high enema. I have not seen anywhere. It's a normal the glycerin or the phosphate enema. We just insert that small tube into the rectum and give the enema. But high up enema means then you have to attach a suction catheter or a red rubber catheter or a Foley's, whatever tube is available, to the enema sachet tube, and then give the enema up, so that you might be able to bypass the loaded hard stools. Low enema is the commonly used one, the normal enema.
Any more questions? Okay. Yeah, Dr. Shavin. Dr. Shavin Shahjahan, do you have a question?
No, sir, no, sir. I just that's
Okay. So let's move on to the patient story, which will be presented by Dr. Joseph. Yeah,
Hello.
Yes, I'm sharing it.
yeah.
Can I share, ma'am?
Yes,
Sir,
you can
yes,
share.
sir.
Okay. I need permission to share, please.
Sir, 1 second.
Okay.
So can you try sharing now?
Yeah. Thank you. Thank you. Thank you. Thank you very much, Dr. Sreedevi, for that wonderful lecture. It was really enlightening. I'm doing a presentation on GI bleed, and can I have the next? So it is a case of a 55-year female with upper gastrointestinal bleeding following NSAID usage. It is not in exactly a palliative care environment. So she's a 55-year female, otherwise healthy. She presented in the emergency room. Next, please. With history of 2 bouts of blood-stained vomiting and a single episode of dark tarry stool. Next one, please. So she sustained a sprained ankle 2 days before that, and she was prescribed naproxen 500 mg twice daily for 5 days. And the next one, please. And she presented 2 days later with a history of 2 bouts of blood-stained vomiting and a single episode of dark tarry stool. There was no abdominal pain or discomfort. She was feeling weak and dizzy. And the next one, please. She has no previous history of hypertension, diabetes, heart or lung disease, or cancer. Next one, please. There is no previous hospitalizations for any condition, no personal or family history of bleeding diathesis or gastric or duodenal ulcer. On examination, the patient was afebrile, conscious, oriented, hypotensive in the supine position with a blood pressure of 90/30, tachycardic with a heart rate of 130 and a respiratory rate of 24 per minute. On abdominal examination, abdomen was soft and non-tender. All quadrants were moving equally with respiration. Next one. The systems were all normal. Hemoglobin was 10.2. Mind you, in this region, being high altitude, their hemoglobin normally is about 16 and above. Hematocrit was 33.4. And all the other blood parameters were within normal limits. And plain X-ray abdomen and ultrasound of the abdomen were unremarkable. So after preparation, since because of that tachycardia and the low blood pressure, she was taken for an upper GI endoscopy. And one significant finding was that there was a hemorrhagic gastric ulcer in the antrum with a visible vessel. Next one, please. So that's the picture of the endoscopy. And the next one, please. The vessel was cauterized at the time of endoscopy. Biopsies of the antrum and body were taken and the procedure was concluded. Biopsies were later reported negative for Helicobacter, and cautery was successful and there was no further bleeding. Psychosocial aspects. She is a 55-year married woman with 2 children. Husband is employed and supportive, and she has a stable family. There are no particular psychosocial concerns expressed except for fear of taking any NSAIDs in the future. So the patient was started on high-dose intravenous proton pump inhibitors for 3 days, pantoprazole 80 mg IV bolus followed by 40 mg 3 times a day IV. She stayed in the hospital for 3 days for observation and to watch for rebleeding. After that, oral PPI was started. The patient was discharged home. The main concern is acute GI bleed in a previously healthy patient with no known predisposing factors. In the summary, she's a 55-year female, otherwise healthy, upper GI bleed following 2 days of treatment with naproxen. And so the discussion points could be what would be the risk factors for GI complications following NSAID therapy, the principles of management of GI bleeding and other adverse effects following NSAID usage. Thank you.
Thank you, sir. So we have a 55-year-old woman with GI bleed who has a history of consumption of naproxen. So anybody would like to comment on what are the risk factors for GI complications when a patient is on NSAID?
Hello, Dr. Kale.
Yes, sir.
Good afternoon. The NSAID or any other drug should not be given like that. They should always be preceded with PPI or ranitidine, whatever it is. We always give it in the morning, and then only we can start NSAID or any other analgesic. So that is a standard dictum, so that the GI bleed can be avoided.
Okay, thank you, sir. So can you also talk about the risk factors of GI bleeding in a patient who is taking NSAID?
Because it depends on how much dose you are giving. You should always give PPI. We always give PPI. Maybe OD, maybe BD also sometimes. I have used pantoprazole 40 milligram BD, and if the patient is on double, especially in palliative setup, if I am giving paracetamol QID as per our standard, and in addition sometimes required diclofenac, then we always give BD. pentaprozole. So we don't encounter any GI bleeding. And there is a standard protocol. We always give PAN 40 or omeprazole 20, whatever is available. But PAN 40 is referred by me.
Okay. Okay, sir. So anybody else want to comment on that perspective?
Sir, I want to know whether without endoscopy we could manage it. I mean, the cauterization of the vessel, if it was not done, was it possible to control the bleeding?
No, earlier, good afternoon. Earlier, in those days when the endoscope was not available, we have used ice, cold milk. We put cold milk and then keep on aspirating with the gas. That has worked to some extent, but it is not guaranteed. But then those days are there. When I was a student, there was no gastroscope. That time we have done with cold milk, and it out of 3, you may get result in 2. It may so happen. It has happened with me also. So I have that experience. No gastroscope was available in those days, in talking about 1975.
So was it given through a rice tube or just ask the patient to drink?
It depends. Normally, we avoided rice tube initially. We ask the
Okay.
patient to take, and then if
Okay.
required, we aspirate.
Mhm.
But then the scenario was that there was no endoscope available. I'm talking about 75. Now
Yeah.
everywhere the endoscope is available, so we don't take any chance. We straight away call for the endoscopist and do this, because nowadays what is you call the evidence-based medicine. So you should always see the blood vessel, clip it, cauterize it, and do the needful. Because nobody will accept nowadays doing that old method of cold milk and all that. Thank you.
Oh. Okay, sir. So that was good to know, because you have managed it during those days where the later equipments were not available.
Mm.
So, Sreedevi, would you like to mention some of the perspectives?
Yeah, I think we should ask by starting any history of any peptic ulcers or any kind of gastric related illness in the past. And this lady is young, so that age related risk is not a problem here. But any history, I think even some literature says that it is even you should ask for any history in the family also with any acid peptic disease, uh, previous history of ulcerations, or after taking any pain medications, did you feel any stomach discomfort? And I think whether she was on any antiplatelet drugs would have been one thing. That I think these are all things that we usually ask. Uh, any history of taking, or is she on any antiplatelet drugs? I think it's best to ask about history of cardiovascular or cerebrovascular illness. So probably they might be on some blood thinners or something. So that would be one thing that we can. I'm very amused to see that she was given naproxen, at least, because that has not been prescribed, seen very commonly these days. Usually we see COX-2, thinking that COX-2 is the safest analgesic, and just prescribe COX-2 for a longer period of time, or at least diclofenac, without thinking that it is very, very safe to be given. And naproxen in that terms is a very known to cause, although it is has a very good analgesic effect for long term, it is known to cause silent erosions, which we come to know only with this kind of late presentation. Ibuprofen and all, or even diclofenac, you will get to know with one dose, but naproxen is generally considered as a silent GI bleeder. But it is a very, very good anti-inflammatory drug. But and nowadays no one prescribes. So I was generally amused to see that someone has actually. I do prefer naproxen personally to take. So I was quite happy to see at least some people are still using this drug. Uh, uh, yeah. So these are the history things which I would ask: history of fastic peptic disease or any familial history, cardiovascular and cerebrovascular illness, so that we'll know whether they are on any blood thinners. Yeah.
Yeah, to add to that, so I'm talking about generally the risk factors for NSAID related GI complications. So age more than 60, and as Sreedevi told, if the person is taking any anticoagulants, and are this person on any steroids, and many of the people will be on low dose aspirin for cardiovascular problems. So that's also another added risk factor. Then the dose of NSAID the patient was on, because as the dose increases, the chance of GI toxicity also increases. And any history of H. pylori infection. So these are some common factors which can increase the risk for GI toxicity. Uh, yeah. Uh, so we have to, when we prescribe patients with NSAID, we have to ask the patients about this possible history, and probably we should also ask whether they are taking enough water, because if patient is not taking enough fluid, then that will also lead on to renal failure. So that's another problem. Yeah. Dr. Chitra mentioned take NSAID after food. Yes, that's correct. And uh, either proton pump inhibitors or H2 receptor antagonists can be used for prophylaxis uh, against the GA bleed. And it is said that about 25% of patients who are on chronic NSAID therapy can develop peptic ulceration, and about 2 to 4% of patients can also develop perforation or bleed. So it's important for us to make sure that patient doesn't end up with these complications. From a GI side effect profile, the ibuprofen is the NSAID which has the lowest GI toxicity. So I think we can go on for ibuprofen, but naproxen has more GI toxicity compared to ibuprofen. And the dose of ibuprofen we should restrict to 1,200 milligram at the most, because otherwise, if you increase the dosage beyond that, it will also act like a specific OX2 inhibitor, so that it will increase the chance of myocardial infarction and stroke. So restrict the dose maximum to 1,200 milligram. And when you give NSAID, please prescribe NSAID at the lowest dose for the shortest possible days. So you need not give 400 milligram TID, maybe 200 milligram BD if it is enough. That should be okay. And prophylaxis with omeprazole or proton pump inhibitors or H2 receptor antagonists like ranitidine. And I see that some literature says the dose should be actually the double that we are using usually. Usually we use 150 milligram BD ranitidine, but literature says it should be 300 milligram BD for prophylaxis. And we know that we are not expert in how to manage the complications, but we know the complications that can occur with NSAID. So, in addition to the gastrointestinal toxicities, NSAIDs are commonly known to produce renal failure, and it also increases with the duration of usage. Even with single dose of NSAID can precipitate renal failure. So we have to select the patients accordingly, because many of the patients who are in palliative care may not be taking food or fluid. They might be dehydrated. Their blood volume will be less. They might have nausea or vomiting, and even diarrhea. So all this will contribute to reduced blood volume, which can lead to renal failure. Then it can increase blood pressure, and it can increase blood pressure both in normotensive individuals as well as hypertensive individuals. And in patients with the cardiovascular problems, it can precipitate even heart failure. And as all of you know, the edema, dependent edema, is another problem which can also occur with NSAID. So NSAID generally the use should be restricted if there is a definite indication. Otherwise, we should avoid the use of NSAID. More and more scientific facts are coming up regarding NSAID. So we should restrict the use of NSAID only if it is definitely indicated, like there is definite inflammation and we think that okay, this patient needs an NSAID. So lowest dose for the shortest possible days. Sorry. Anybody else?
So in this case, whoever was in the casualty at the time happened to prescribe that, and that was a lesson, costly lesson we learned. And Dr. Kale's comments are really good in the sense that there are many places where we may not have access to an endocrinologist, an endoscopist. And so giving ice cold milk or whatever, when we can't do anything else, I think that is a very useful tip. And I mentioned in the history that there was no family history of bleeding diathesis or gastric problems, and she herself was not on any blood thinning agents. Yeah. But those are really valuable suggestions. Thank you, sir.
So thank you, sir, for presenting this patient story, and thank you, Sreedevi, for being with us for another session, and was good to know about how to manage intestinal obstruction in a palliative care setting, and the importance of managing constipation. So thank you, Sreedevi, and thank you all. Forward to that lecture.